Hello, everyone. Today we begin Chapter 19, which focuses on microbial diseases of the skin and wounds. When we say microbial diseases, we are talking about infections caused by microorganisms such as bacteria, viruses, fungi, and parasites. The skin is the largest organ in the human body, and most of the time it protects us extremely well. However, when microbes get past this barrier, especially through cuts, burns, or other injuries, they can cause disease. In this chapter, we will study what normally protects the skin, what lives on the skin, and what happens when certain microbes invade and cause infection. Before we talk about infections, we need to understand how the skin is built and what it does. The skin has several important functions. First, it prevents excessive water loss. Without skin, our bodies would dry out quickly. Second, it helps regulate temperature. When you sweat, your body cools down. When you are cold, blood flow to the skin decreases to conserve heat. Third, the skin is involved in sensation. It allows you to feel pain, pressure, heat, and cold. Fourth, it helps form vitamin D when exposed to sunlight. Finally, and most important for microbiology, the skin acts as a physical barrier against microbial invaders. Structurally, the skin has two main layers, the epidermis and the dermis. The epidermis is the outer layer. It is thinner and made mostly of tightly packed cells. The dermis lies underneath and is thicker. It contains blood vessels, nerves, hair follicles, and glands. Understanding these layers is important because different infections affect different depths of the skin. In this figure, you can visually see the layers we just discussed. The top layer is the epidermis. The very outermost part of the epidermis consists of dead, flattened cells that are filled with keratin. Keratin is a tough protein that makes the skin strong and resistant to damage. These dead cells form a protective shield. Below the epidermis is the dermis. The dermis contains structures like hair follicles, sweat glands, oil glands, blood vessels, and nerve endings. Notice that microbes sitting on the surface are not automatically in your bloodstream. They would need to break through multiple layers to reach deeper tissues. This layered structure is one reason healthy skin is such an effective defense against infection. Now let's talk about wounds. A wound is any trauma or injury that breaks tissue. This can include cuts, scrapes, surgical incisions, burns, or even animal bites. When the skin is intact, microbes usually cannot get inside the body. But when there is a wound, that protective barrier is broken. Once the barrier is broken, microbes can enter deeper tissues. In many cases, your immune system quickly recognizes and eliminates these invaders. However, if the microbes multiply faster than your immune system can control them, infection develops. Some infections remain localized, meaning they stay in one area. Others can spread and become severe or even life-threatening. This is why proper wound care is so important in healthcare settings. Let's think critically. Why can't most microbes easily grow on the surface of the skin? First, the skin is dry. Many microbes require moisture to grow. Second, the skin is slightly acidic. This acidity creates an environment that is not ideal for many pathogens. Third, the outer epidermal cells are dead and constantly shedding. If microbes attach, they are often shed off with these dead cells. Fourth, sweat and oil glands produce substances that contain antimicrobial chemicals. In simple terms, the skin is dry, acidic, and constantly renewing itself. That combination makes it a very unfriendly place for many microorganisms. This is why intact skin is such a powerful first line of defense. Now, here is something interesting. Even though the skin is hostile to many microbes, it is not sterile. The skin has its own microbiome. The microbiome refers to the collection of microorganisms that normally live on and inside the human body. The skin microbiota are usually harmless and often beneficial. These microbes compete with potential pathogens for nutrients and space. Think of it like parking spots. If all the parking spots are taken by harmless bacteria, there is no room for harmful ones to move in. Also, these normal microbes cannot be completely removed by washing. You can reduce their numbers, but they quickly return. They tend to grow best in moist areas like the armpits, groin, and between the toes. Some of their waste products are responsible for body odor. The skin microbiome includes different types of organisms. There are bacteria such as Staphylococcus, Micrococcus, and diphtheroids. There are also yeasts such as Malassezia. Under normal conditions, these organisms live peacefully on the skin. However, these normally harmless microbes can sometimes cause disease. This usually happens if they penetrate through the epidermis, for example, through a cut, or if the immune system is weakened. So the same bacteria that are harmless on the surface can become dangerous if they enter deeper tissues. This concept is very important. Location matters in microbiology. Why do we consider the normal microbiome beneficial? Because it protects us. These normal microbes prevent harmful pathogens from colonizing the skin by competing for nutrients and attachment sites. Some even produce substances that inhibit the growth of other bacteria. If we completely eliminated our normal microbiota, harmful organisms might have an easier time taking over. This is similar to what can happen after broad-spectrum antibiotic use, where removing normal flora allows opportunistic pathogens to grow. So in many cases, the microbes living on us are part of our defense system rather than our enemies. Now we begin specific diseases, starting with folliculitis. Folliculitis is an infection of the hair follicle. A hair follicle is the small sac in the skin from which hair grows. When it becomes infected, you often see a small red bump filled with pus. Many people simply call this a pimple. If folliculitis occurs at the base of the eyelid, it is called a stye. If the infection spreads deeper into surrounding tissues, it can form a larger painful abscess called a furuncle, commonly known as a boil. If multiple furuncles join together, they form a carbuncle, which is even larger and more serious. So what starts as a small infection can become more extensive if not controlled. The most common cause of folliculitis is bacteria from the genus Staphylococcus. These bacteria are gram-positive, meaning they retain the crystal violet stain in the gram stain procedure. They are spherical in shape and typically appear in clusters that look like grape bunches under the microscope. Staphylococcus bacteria are very hardy. They can tolerate salt and dryness better than many other bacteria, which is one reason they survive well on the skin. Two common species found on human skin are Staphylococcus epidermidis and Staphylococcus aureus. S. Epidermidis is usually harmless and part of the normal microbiome. S. aureus, however, is more virulent and can cause a variety of infections, especially if it enters deeper tissues. Understanding the difference between colonization and infection is critical here. In this figure, you see what Staphylococcus looks like under the microscope. Notice the round shape of the bacteria. Round bacteria are called cocci. Also notice how they are arranged in clusters that resemble bunches of grapes. That grape-like clustering pattern is a classic identifying feature of Staphylococcus. When we perform a gram stain, these bacteria appear purple because they are gram-positive. The thick peptidoglycan layer in their cell wall traps the stain. Recognizing both the gram-positive color and the cluster arrangement helps clinicians identify this organism quickly in a lab setting. When pus from a wound is examined and you see gram-positive cocci in clusters, Staphylococcus is strongly suspected. This table compares Staphylococcus epidermidis and Staphylococcus aureus. Both species can live on the skin, but they are not equally dangerous. Staphylococcus epidermidis is generally less virulent. It lacks many of the aggressive virulence factors that cause tissue damage. It usually only causes disease when it gets access to medical devices like catheters or prosthetic joints, especially in hospitalized or immunocompromised patients. Staphylococcus aureus, on the other hand, has many virulence factors. Virulence factors are tools that help a microbe cause disease. These include toxins that damage tissues, enzymes that help the bacteria spread, and surface proteins that help it stick to cells. Because of these factors, S. aureus can cause much more severe infections. Clinically, this is why S. aureus infections tend to be more aggressive and sometimes life-threatening. Now let's discuss how folliculitis actually develops. Staphylococcus is commonly transmitted by direct contact. This can occur through skin-to-skin contact or indirectly through objects, which we call fomites. Examples include towels, razors, or gym equipment. When the bacteria enter through small breaks in the skin, they multiply inside the hair follicle. If the infection remains localized, it forms a small pimple-like lesion. However, if it spreads deeper, it can enter the bloodstream. Once in the blood, it can travel to distant organs. This is why even a seemingly small skin infection should not be ignored if symptoms worsen. Staphylococcus aureus temporarily colonizes the skin or nasal passages of many healthy people, meaning they carry it without symptoms. But if it gains access to deeper tissues, infection can develop. This table highlights that S. aureus does much more than cause pimples. It can cause a wide range of diseases. These include skin infections, pneumonia, bloodstream infections, food poisoning, and toxic shock syndrome. This shows how versatile and dangerous this organism can be. The key concept here is that one organism can cause multiple types of disease depending on where it enters the body and what virulence factors are expressed. For example, if it stays on the skin, it may cause an abscess. If it produces toxins in contaminated food, it causes food poisoning. If it enters the bloodstream, it can cause sepsis. Location and toxin production matter. Diagnosis of a staphylococcus infection often involves examining pus under a microscope. If gram-positive cocci in grape-like clusters are observed, that strongly supports staphylococcus. Culture tests may confirm the species. Treatment depends on severity. Mild infections may be treated with topical antibiotics like mupirocin. More serious infections may require oral antibiotics such as dicloxacillin. However, some strains are resistant to common antibiotics. MIRESA, which stands for methicillin-resistant Staphylococcus aureus, is resistant to many drugs and may require treatment with vancomycin. Prevention focuses heavily on hygiene. Hand washing, proper wound care, and infection control in hospitals are critical. In healthcare settings, strict protocols are necessary to prevent MRSA transmission. Staphylococcal scalded skin syndrome, or SSS, is a more serious condition caused by certain strains of S. aureus. In this disease, the skin becomes red, wrinkled, and blistered. Eventually, the outer layer of the epidermis peels off and sheets. It looks similar to a severe burn, which is why it is called scalded skin. The key thing to understand is that this condition is caused by toxins released by the bacteria. The toxins damage the connections between skin cells. Importantly, the deeper layer, the dermis, is not affected. That is why scarring usually does not occur. Although death is rare, complications can arise if secondary infections develop after the protective skin barrier is lost. In this image, you can see widespread peeling of the outer skin. Notice how the epidermis appears to detach. This visual helps reinforce the idea that toxins are separating the top layer of skin from the rest. In infants especially, the skin barrier is more delicate, making them more susceptible. Clinically, when you see widespread sloughing of skin in a child, SSS must be considered. Early antibiotic treatment is essential to stop toxin production. This condition primarily affects infants and young children. Their immune systems are not fully developed and they may not clear the toxin efficiently. The bacteria spread person to person, often in hospital settings such as neonatal units. Diagnosis is usually based on the characteristic peeling skin. Treatment involves antimicrobial drugs to eliminate the bacteria producing the toxin. Because S. aureus is so common in the population, prevention is challenging. Strict hygiene and infection control in healthcare settings are essential. Impetigo and erysipelas are additional bacterial skin infections. Impetigo commonly presents as red patches that form blisters and crust over. It often occurs on the face and limbs of children. The lesions may have a honey-colored crust. Erysipelas is a deeper infection that spreads into the lymphatic system. It typically appears as a raised, bright red area with well-defined borders. Patients may also develop fever. While impetigo is usually superficial, erysipelas involves deeper tissues and can be more serious. In this image, you can see the characteristic crusted lesions of impetigo. These lesions are usually superficial, meaning they affect only the outer layers of skin. The honey-colored crust is a classic feature. Impetigo is most common in children because they often have minor skin injuries and close contact with others. It spreads easily through direct contact or shared items. Early treatment with topical or oral antibiotics prevents complications and limits transmission. In this image, you can see erysipelas. Notice that the affected area is bright red, swollen, and has clearly defined borders. That sharp edge is an important clue. Unlike impetigo, which is superficial, erysipelas involves deeper layers of the skin and often the lymphatic vessels. Patients frequently have systemic symptoms such as fever and chills. When you see redness that is spreading, warm to the touch, and associated with fever, you should think about a deeper bacterial infection rather than a simple rash. Clinically, this distinction matters because deeper infections require systemic antibiotics. Both impetigo and erysipelas occur when bacteria enter through compromised skin. This could be from a small cut, insect bite, eczema, or even scratching. Most cases are caused by Staphylococcus aureus, but Streptococcus pyogenes can also cause these infections. In impetigo, the infection remains more superficial. In erysipelas, bacteria spread through lymphatic vessels. A potential complication is acute glomerulonephritis, which is kidney inflammation that can occur after certain streptococcal infections. That means a skin infection can eventually affect the kidneys. Impetigo is most common in children, especially in crowded conditions. Erysipelas can affect both children and the elderly. Transmission occurs through direct contact or contaminated objects. Impetigo is usually diagnosed by the presence of characteristic vesicles and crusted lesions. Vesicles are small, fluid-filled blisters. Erysipelas is diagnosed by the appearance of spreading redness and associated fever. Impetigo is treated with careful cleaning and topical or oral antibiotics depending on severity. Erysipelas typically requires systemic antibiotics such as penicillin. Prevention focuses on hygiene, wound care, and minimizing skin trauma. In nursing practice, teaching families about hand washing and proper wound cleaning is a key intervention. Necrotizing fasciitis is a severe and rapidly progressing infection. The name literally means infection that causes death of fascia, which is connective tissue beneath the skin. Early symptoms may look mild: redness, swelling, and intense pain at the infection site. However, the pain is often much worse than what you would expect based on appearance. That disproportionate pain is a red flag. As the infection spreads, patients may develop fever, nausea, weakness, and even confusion. The infection destroys tissue quickly. Because it spreads along tissue planes, it can advance rapidly within hours. This condition is sometimes called flesh-eating disease. Although the bacteria are not actually eating the tissue, they are destroying it through toxins and enzymes. Most cases are caused by Streptococcus pyogenes, also known as group A Streptococcus. These bacteria produce enzymes that help them spread through tissues. They also produce toxins such as exotoxin A and streptolysin S, which damage cells and trigger a strong inflammatory response. The bacteria typically enter through a break in the skin. Even a minor cut can serve as an entry point. Once inside, they multiply rapidly and release substances that destroy tissue and impair blood flow. Reduced blood flow means immune cells and antibiotics have difficulty reaching the infected area. This disease can spread person to person, but many cases occur after minor trauma. Mortality is significant, around 20% or higher in some studies. Early diagnosis is challenging because initial symptoms can resemble less serious infections. Treatment requires immediate and aggressive intervention. Patients are treated with intravenous antibiotics such as clindamycin and penicillin. Most importantly, surgical removal of dead tissue is essential. Without surgery, antibiotics alone are often not enough. The key nursing takeaway is early recognition of severe pain, rapid progression, and systemic symptoms. Acne is a very common skin condition, especially in adolescents. It is commonly associated with Propionibacterium acnes, now called Cotibacterium acnes. This is a gram-positive, rod-shaped bacterium that normally lives on the skin. This organism is part of the normal microbiome. It usually does not cause problems. However, during puberty, hormonal changes increase oil production in the skin. The oil glands become more active and pores can become clogged. When pores are blocked, bacteria multiply inside the follicle, leading to inflammation. This figure shows how acne develops step by step. First, excess oil and dead skin cells block a pore. Then bacteria multiply inside the blocked follicle. The immune system responds, causing redness and swelling. This results in a pimple. Most acne is not dangerous, but severe cases can cause scarring. Treatment may include topical antibiotics, medications that promote exfoliation, or systemic drugs such as isotretinoin for severe cases. The key concept is that acne results from a combination of blocked pores, bacterial growth, and inflammation. Propionibacteria are normal residents of the skin, so acne is not considered a contagious disease. It usually begins during adolescence due to hormonal changes, but can continue into adulthood. Diagnosis is made by visual examination. Treatment may include antimicrobial drugs to reduce bacterial numbers and medications that help remove dead skin cells. Ultraviolet light may sometimes be used to reduce bacteria. Severe acne may require strong medications that regulate oil production. Nursing education often focuses on medication adherence and managing side effects. Cat scratch disease is caused by Bartonella henselae. Patients often develop fever, fatigue, and swelling near the site of a cat scratch or bite. The lymph nodes near the infection site may become enlarged and tender. This bacterium is transmitted by cats, particularly kittens, and sometimes by fleas. The organism produces endotoxin, which contributes to inflammation. Diagnosis is typically made through blood tests that detect antibodies. Treatment involves antimicrobial drugs, and prevention includes avoiding rough play with cats and practicing proper wound cleaning after scratches. In this image, you can see swelling and redness near the site of infection. Cat scratch disease often begins as a small bump at the scratch site. Over time, nearby lymph nodes enlarge. Remember, lymph nodes are part of the immune system. When they swell, it usually means the body is responding to infection. This disease is generally self-limited, meaning it often resolves on its own in healthy individuals. However, in immunocompromised patients, complications can occur. When assessing a patient with swollen lymph nodes and a recent cat scratch, this diagnosis should be considered. Now we move to Pseudomonas aeruginosa, which is a very important opportunistic pathogen. In severe cases, especially when it enters the bloodstream, it can cause fever, chills, and even shock. One interesting feature is that this bacterium produces a blue-green pigment called piocyanin. In massive infections, wounds may have a bluish or greenish discoloration. Pseudomonas is a gram-negative rod. It lives in soil, water, and moist environments. Despite having many virulence factors, it rarely causes disease in healthy individuals. It mainly infects people who are immunocompromised or who have significant tissue damage, such as burn patients. In this image, you can observe the discoloration and tissue damage associated with Pseudomonas infection. In burn patients, the protective barrier of the skin is gone, making it easy for bacteria to invade. Once Pseudomonas enters damaged tissue, it produces toxins and enzymes that destroy cells and impair immune responses. Because it thrives in moist environments, hospital settings, especially intensive care units, must be very careful about infection control. Pseudomonas infection is especially dangerous in burn victims. Burns create large areas of dead tissue. Dead tissue has poor blood supply, meaning immune cells and antibiotics have difficulty reaching the site. The bacteria grow beneath the surface of the burn and release toxins that destroy tissue and can trigger systemic shock. Treatment often requires debridement, which means surgically removing dead tissue. Without debridement, topical antibiotics cannot penetrate effectively. This highlights the importance of both surgical and pharmacological treatment. Pseudomonas is widespread in water and soil. It is not usually part of the normal human microbiome. When it infects, it can affect almost any organ system once inside the body. Diagnosis may be challenging. The blue-green pigment can be a clue in severe cases. Treatment typically requires a combination of antibiotics because Pseudomonas is often resistant to multiple drugs. This multi-drug resistance makes it a major concern in hospitals. Prevention involves careful wound care and strict infection control practices. Now we shift to Rocky Mountain spotted fever, which is caused by Rickettsia rickettsii. This organism is different from typical bacteria. It is a gram-negative intracellular parasite, meaning it must live inside host cells to survive. Unlike many bacteria, Rickettsia does not produce toxins and does not use glucose as its main nutrient. Instead, it damages cells by invading and multiplying within them. This disease is transmitted by ticks. The hallmark symptom is a non-itchy spotted rash that often begins on the trunk and spreads to the arms and legs. Patients may also develop fever, headache, and muscle pain. In severe cases, organ failure can occur. The damage happens because the bacteria infect the cells lining blood vessels. When blood vessels are damaged, leakage and inflammation occur, which explains the rash and potential organ complications. When an infected tick bites a person, the bacteria enter the bloodstream. They invade endothelial cells which line the inside of blood vessels. Once inside these cells, the bacteria multiply and damage the vessel walls. This causes inflammation and leakage of fluids. The resulting rash is actually due to blood vessel damage, so the visible skin findings reflect deeper vascular injury. As more blood vessels become damaged, organs may receive inadequate blood supply. This can lead to serious complications, including kidney failure or neurological symptoms. The key point is that the rash is not just a skin problem. It represents systemic vascular damage. Early treatment with appropriate antibiotics is critical to prevent severe outcomes. This map shows where cases are most common in the United States. Despite the name, Rocky Mountain spotted fever is more prevalent in the Appalachian region and parts of the southeastern U.S. Cases are more common in warmer months, particularly May, June, and July. This is because tick activity increases during warmer weather and people spend more time outdoors. Prevention involves avoiding tick-infested areas, wearing protective clothing, and using insect repellent. Rocky Mountain spotted fever is transmitted through the bite of an infected tick. Ticks act as vectors, meaning they carry the pathogen from one host to another. The disease is most common in regions where tick populations are high, especially in wooded or grassy environments. Diagnosis is often based on clinical suspicion, especially if a patient has fever, rash, and recent tick exposure. Blood tests can confirm infection, but treatment should not be delayed while waiting for results. Early antibiotic therapy is critical because delays increase the risk of severe complications. Prevention focuses on avoiding tick bites by using repellents, wearing long sleeves and pants, and performing tick checks after outdoor activities. Cutaneous anthrax is caused by Bacillus anthracis. This bacterium forms endospores, which are extremely resistant survival structures. Endospores allow the bacteria to survive harsh environmental conditions for long periods. When spores enter the skin through a cut, they germinate and multiply. The hallmark lesion is an eschar, which is a black painless ulcer. The black appearance is due to tissue death. Although the lesion looks dramatic, it is often not painful. Cutaneous anthrax can be treated effectively with antibiotics if recognized early. Prevention mainly involves controlling infection in livestock, since animals are common reservoirs. Gas gangrene is a severe infection characterized by rapid tissue destruction. Patients may notice sudden pain, swelling, and discoloration of the affected area. The tissue may turn black due to necrosis, which means tissue death. One distinctive feature is the presence of gas bubbles in the tissue. These bubbles form because the bacteria produce gases as metabolic byproducts. The skin may feel crackly when touched, a sensation known as crepitus. This infection progresses quickly and is a medical emergency. Gas gangrene is most commonly caused by Clostridium perfringens, although other Clostridium species can also be responsible. These bacteria are anaerobic, meaning they grow best in environments without oxygen. They are also endospore-forming organisms, allowing them to survive in soil. When spores enter deep, poorly oxygenated tissue, such as after trauma, they germinate. The bacteria produce multiple toxins, some of which destroy cell membranes and connective tissue. This leads to rapid muscle and tissue death. The lack of oxygen in damaged tissue creates an ideal environment for these bacteria. This overview emphasizes how serious gas gangrene is. The mortality rate can exceed 40%, especially if treatment is delayed. The infection typically follows a traumatic event that introduces spores into deep tissue. Diagnosis is often based on clinical appearance, including blackened tissue and gas formation. Immediate treatment is essential. Surgical removal of dead tissue is critical because antibiotics alone are not sufficient in dead, poorly perfused areas. Antitoxins and antimicrobial drugs are also administered. Proper wound cleaning after injuries is key to prevention. Most cases occur in late spring and summer. Why? Because tick activity increases in warmer months. Ticks are more active when temperatures rise and people spend more time outdoors hiking, camping, or gardening. Increased exposure leads to increased transmission. Understanding seasonality helps clinicians maintain suspicion during high-risk periods. Now we transition from bacterial diseases to viral diseases. Many viral infections are systemic, meaning they affect the entire body rather than just one localized area. However, even systemic viral infections often produce visible skin manifestations such as rashes or lesions. The key difference between bacterial and viral skin infections is that viruses must enter host cells to replicate. They hijack cellular machinery. As infected cells die or the immune system responds, visible skin changes occur. Pox viruses are DNA viruses that cause distinctive skin lesions. The most well-known poxvirus disease is smallpox, which has been eradicated globally through vaccination. This is one of the greatest achievements in public health history. Other poxviruses include monkeypox, cowpox, and orf. These are less common in humans. Poxvirus infections progress through characteristic stages, starting as flat spots and developing into fluid-filled lesions and eventually scabs. This figure shows how poxviral lesions develop over time. First, there are macules, which are flat, discolored spots. These progress to papules, which are raised bumps. Then vesicles form, which are fluid-filled blisters. These become pustules filled with pus and finally scab over. Understanding lesion progression is important clinically. In smallpox, all lesions tend to be in the same stage at the same time. In contrast, in chickenpox, lesions are often in different stages simultaneously. That distinction is often tested in nursing and medical exams. Poxviruses are DNA viruses that produce proteins interfering with the immune response. Smallpox infection begins when the virus is inhaled. It first infects the respiratory tract and then spreads through the bloodstream to the skin. The skin lesions are the result of viral replication in dermal cells and the immune response to infected cells. Vaccination was highly effective in eliminating smallpox. Today, routine vaccination is no longer performed in the general population, but certain military and laboratory personnel may still be vaccinated due to potential exposure risks. Although smallpox has been eradicated, it is important to understand its history and current relevance. The variola virus, which causes smallpox, is officially stored only in secure laboratories in the United States and Russia for research purposes. Smallpox was eliminated through a global vaccination campaign, and routine vaccination stopped in the 1970s. However, other poxviruses such as monkeypox have increased in recent years. Monkeypox spreads through close contact and sometimes through respiratory droplets. Treatment for poxvirus infections may involve vaccination shortly after exposure. The smallpox vaccine is highly effective if given early. Prevention depends on vaccination, isolation of infected individuals, and public health surveillance. Herpes infections are caused by human herpes viruses, mainly herpes simplex virus type 1 and type 2. These viruses cause slow-spreading skin lesions that often appear as clusters of small, painful blisters. HSV-1 typically causes oral herpes, sometimes called cold sores. HSV-2 is more commonly associated with genital herpes, although both types can infect either location. One important feature of herpes infections is recurrence. After the initial infection, the virus remains in the body in a latent or dormant state. Later stress, illness, or immune suppression can reactivate the virus, leading to new lesions. Herpes viruses are DNA viruses. They produce proteins that help them evade the immune system. After initial infection of epithelial cells, the virus travels along sensory nerves to nerve ganglia, where it becomes latent. The painful lesions result from viral replication and inflammation when the virus reactivates. Herpes viruses are DNA viruses. They produce proteins that help them evade the immune system. After initial infection of epithelial cells, the virus travels along sensory nerves to nerve ganglia, where it becomes latent. The painful lesions result from viral replication and inflammation when the virus reactivates. Infected cells may fuse together, forming structures called syncytia. This cell fusion is a classic microscopic finding in herpes infections. The key concept is latency. Once infected, the virus remains in the body for life. This image shows typical oral herpes lesions. Notice the grouped blisters on a red base. These lesions are usually painful and may rupture, forming crusts. Patients often describe tingling or burning before the blisters appear. That early sensation is called a prodrome. Recognizing the prodrome can help patients start antiviral medication early to reduce severity and duration. This figure demonstrates how the virus travels from the skin or mucous membranes to sensory nerve ganglia. During primary infection, the virus replicates at the surface. It then enters nerve endings and moves to ganglia, where it remains dormant. During reactivation, the virus travels back down the nerve to the skin, causing new lesions in roughly the same location. This explains why recurrent cold sores often appear in the same spot. This table compares different herpes viruses. HSV1 and HSV2 cause localized lesions and establish latency in sensory nerves. Other herpes viruses, like varicella-zoster virus, also establish latency but in different nerve ganglia. Understanding the differences between herpes viruses is important because their transmission patterns, disease severity, and complications vary. For example, neonatal herpes infections can be severe and even fatal, especially if transmitted during birth. Herpes spreads through direct contact between mucous membranes or broken skin. Oral herpes spreads through saliva or close contact. Genital herpes spreads through sexual contact. In healthy adults, herpes is usually not life-threatening, but neonatal infections can be severe. Diagnosis is often based on the appearance of lesions. Laboratory tests can detect viral antigens. Antiviral medications such as acyclovir help control outbreaks but do not cure the infection. Preventive measures include avoiding contact during active outbreaks and using barrier protection. Warts are benign growths caused by papillomaviruses. These viruses infect epithelial cells and cause them to proliferate excessively. The result is a raised, rough lesion on the skin or mucous membranes. Most warts are harmless and resolve spontaneously. However, certain strains of human papillomavirus, or HPV, can activate oncogenes in host cells and contribute to cancer development, particularly cervical cancer. Warts develop slowly, often months after infection. Papillomaviruses enter through tiny breaks in the skin. Transmission occurs through direct contact or contaminated objects. Individuals can also spread warts from one part of their body to another. Diagnosis is usually based on observation. Treatment options include freezing, chemical removal, or surgical excision. Even after removal, new warts may develop because the virus can remain latent in nearby cells. Chickenpox is caused by varicella-zoster virus, or VZV. It is highly contagious and characterized by a widespread rash that begins on the trunk and spreads outward. Lesions appear in different stages at the same time. Some are blisters, some are crusted, and some are just beginning. After recovery, the virus does not leave the body. It becomes latent in sensory nerve ganglia. Years later, especially when immunity declines, the virus can reactivate and cause shingles. Shingles presents as painful localized lesions along the path of a single nerve. Pain may persist even after the rash heals, a condition called postherpetic neuralgia. This overview slide summarizes both chickenpox and shingles, which are caused by the same virus, varicella-zoster virus, or VZV. The important concept here is that one virus causes two different diseases at different times in a person's life. Chickenpox is the primary infection. It usually occurs in childhood and is characterized by a widespread itchy rash. After the infection resolves, the virus does not leave the body. Instead, it becomes latent in nerve ganglia. Years or even decades later, if immunity weakens, the virus can reactivate and cause shingles. Shingles is not a new infection from outside. It is a reactivation of the same virus already inside the body. This concept of latency and reactivation is central to understanding herpes viruses. Varicella-zoster virus spreads initially through the respiratory tract. A person inhales viral particles, which infect cells in the upper respiratory system. The virus then enters the bloodstream and lymphatic system, spreading throughout the body. When the virus reaches the skin, it infects dermal cells, causing the characteristic chickenpox rash. The rash forms because infected cells are destroyed and the immune system responds with inflammation. After recovery, the virus travels along sensory nerves to nerve ganglia, where it remains dormant. Later reactivation causes shingles, which typically affects a localized area corresponding to one nerve distribution called a dermatome. Before vaccination became common, about 90% of children were infected with VZV. Chickenpox is highly contagious and spreads through respiratory droplets or direct contact with lesions. The disease is generally mild in children but more severe in adults. About 15 to 20% of people who have had chickenpox will develop shingles later in life. The risk increases with age because immune function gradually declines. Diagnosis is usually based on the appearance of lesions. Treatment focuses on symptom relief, although antiviral drugs may be used in severe cases. A vaccine is available to prevent chickenpox, and another vaccine is recommended for older adults to reduce the risk of shingles. Rubella, sometimes called German measles, is a viral disease that causes a mild rash in children. The rash is usually less severe than measles. However, in adults, rubella can cause complications such as arthritis or encephalitis, which is inflammation of the brain. The most serious concern with rubella is congenital infection. If a pregnant woman becomes infected, the virus can cross the placenta and infect the fetus. This can result in birth defects, miscarriage, or fetal death. Therefore, preventing rubella in women of childbearing age is a major public health priority. Rubella virus enters through the respiratory tract and spreads through the bloodstream to various tissues. The rash is partly due to the immune response to infected cells. Interestingly, the immune response contributes more to disease severity in adults than in children. In congenital infections, the virus interferes with fetal development, which explains the risk of birth defects. Understanding this mechanism highlights why vaccination is so critical. This figure demonstrates how vaccination dramatically reduced rubella cases. After widespread immunization programs were introduced, cases dropped sharply. This visual reinforces the power of vaccines in public health. The goal of rubella vaccination is not only to protect individuals, but also to prevent congenital rubella syndrome by protecting pregnant women and their unborn children. Measles is caused by the measles virus and is highly contagious. Early symptoms include fever, cough, runny nose, and conjunctivitis. One characteristic sign is Koplik spots, which are small white lesions inside the mouth. Later, a widespread rash develops. Measles can cause serious complications, especially in children, including pneumonia and a rare but fatal neurological condition called subacute sclerosing panencephalitis. Measles is more severe than rubella and spreads very easily through respiratory droplets. This image shows Koplik spots inside the mouth. These small white lesions on the inner cheek are considered a classic sign of measles and appear before the rash develops. Recognizing Koplik spots is important for early diagnosis. Since measles is highly contagious, early identification allows isolation and prevents further spread. This table compares measles and rubella. Although both cause rashes and spread through respiratory droplets, measles is generally more severe and more contagious. Rubella is usually mild in children but dangerous for fetuses. Understanding these differences helps prevent confusion. Measles causes more systemic illness and higher complication rates. Both diseases are preventable with vaccination, specifically the MMR vaccine, which protects against measles, mumps, and rubella. Measles spreads rapidly through respiratory droplets. Humans are the only host, meaning eradication is theoretically possible with sufficient vaccination coverage. Vaccination has significantly reduced measles cases. However, outbreaks still occur when vaccination rates decline. Diagnosis is usually based on clinical presentation and confirmed by laboratory testing. Treatment focuses on supportive care, including vitamin A supplementation and sometimes antiviral medications. The key public health lesson here is that high vaccination rates are necessary to maintain herd immunity and prevent outbreaks. This slide shows how measles cases have changed over time. Before the measles vaccine was introduced, measles outbreaks happened regularly, often every year or every few years. Large numbers of children became infected because the virus spreads extremely easily through the air. After the vaccine was introduced, cases dropped dramatically. This is a classic example of how vaccination can control infectious disease. However, the graph likely shows that cases did not drop to zero permanently. When vaccination rates decrease in certain communities, outbreaks can return. This reminds us that herd immunity only works if a high percentage of the population is vaccinated. Measles is so contagious that about 95% of people need immunity to prevent sustained outbreaks. Fifth disease is caused by parvovirus B19. It is usually a mild viral illness in children. The classic symptom is a bright red rash on the cheeks, often described as a slapped cheek appearance. After that, a lacy or net-like rash may appear on the body. Most children recover without complications. However, in adults, especially women, it can cause joint pain. In people with certain blood disorders, it can temporarily stop red blood cell production. This is because parvovirus B19 infects precursor cells in the bone marrow that develop into red blood cells. So while this disease is usually mild, it can be serious in specific populations. Parvovirus B19 spreads through respiratory droplets. After entering the body, it infects cells in the bone marrow that are responsible for producing red blood cells. The rash that appears later is actually due to the immune response, not direct viral destruction. By the time the rash shows up, the person is usually no longer contagious. This is important clinically because isolation is most critical before the rash appears, not after. In pregnant women, infection can sometimes affect the fetus, so monitoring may be required. Roseola is caused by human herpes virus 6 and sometimes human herpes virus 7. It typically affects infants and toddlers. The classic presentation is a sudden high fever that lasts for several days. Then, as the fever suddenly drops, a pink rash appears. Parents often worry because the fever can be quite high, sometimes leading to febrile seizures. However, once the rash appears, the child is usually recovering. This pattern, high fever first, rash later, is the key distinguishing feature of roseola. The virus spreads through saliva and infects immune cells. Like other herpes viruses, it can establish latency after the initial infection. The rash is not directly caused by the virus damaging the skin. Instead, it results from the immune response when the body begins clearing the virus. This concept is important. Many viral rashes are immune-mediated, meaning the immune system's reaction creates the visible symptoms.